to moderate this satellite symposium today, the 4th of March 2022. And I'm very delighted to introduce our speaker, Professor Regis Peffault Latour. He's a full professor of hematology at the Hematology Department of Moira Transplant in St. Louis Hospital in France. He's the head of BMT in the same department. He's the president of the French network of the immunological and hematological disorders since 2014. And he is the secretary of the Severe Aplastic Anemia Working Party in the EBMT since 2014. He is a reference in the French Center for Aplastic Anemia since 2007, and his primary area of interest is on aplastic anemia and PNH. He has published extensively in the field of hematology and particularly bone marrow failure and stem cell transplant and PNH. And I'm very delighted to introduce him to kindly give us a talk on PNH, what is new. And before we ask Professor Regis to kindly start, I would like you to stay with us and please complete the post-session survey. So kindly, Prof. Regis Peffault Latour, kindly start the presentation on what's new on PNH.
Good morning, everybody, and thanks a lot for this kind invitation. I would say that PNH is a transforming moment of his history with really some new stuff that is always very exciting to discuss. So again, thanks for allowing me to discuss this with you this morning. So I'm Regis Peffault Latour. I'm working in Paris and Hospital, and as I was kindly introduced, I'm kind of passion for aplastic anemia, PNH, and transplantation. So that is my disclosures, basically, all in the field of PNH and aplastic anemia. And of course, if you are speaking about what is new, you have to speak about what is old. So since 2007, eculizumab was on site for treating PNH, and I did not spend enough time probably on the disease itself. Just to precise that I'm not going to speak about aplastic anemia. I'm going to speak about hemolytic PNH patients who are, of course, deeply involved in hemolysis, crisis, abdominal pain, and stuff like this. I would really focus my talk because of a matter of time and all the new informations I'd like to share with you on those particular patients. So yes, so that was the past eculizumab. It was a transformation for patients, already a revolution 15 years ago, because it was reducing drastically and for some patients giving transfusion independence. And on the other side was also protecting from thrombosis, and as you know, was the main risk factors for death in this population. So there was a randomized trials that arise to approval for that drugs quickly worldwide. And then in the coming years, in the years after, there was some registry studies that confirmed that the drugs in real life was also very efficient. This is the English Britain experience was showing that patients who were receiving eculizumab was having a compared overall survival with some healthy controls, and that, as I was telling to you, the number of transfusion was deeply reduced by the treatment. Another real-life experience was coming from our French reference center, and as you can see again, we were showing that eculizumab was drastically improving overall survival. It was a match comparison between patients who were not able to receive eculizumab because they have been diagnosed before 2007, and patients who were receiving the treatment because the drug was available since 2007 and after. So this is the graph on the left side, and as you can see, on the right side, we, of course, had many statistical intervention to test the role of eculizumab in this population, and it was always associated with better overall survival. So, obviously, eculizumab was a transformation of those patients, and in the years coming after, it was trying to improve the way and the route of administration of that drugs, because as you know, eculizumab is giving every 2 weeks time, lifelong, and the patients were deeply impacted by the treatment, giving such burden timing, and they have to come to the hospital even on a daily care basis. The home care, it was also impacting because you need a half day to do the injection. So there was other route of administration that was developed. There was this ravulizumab that is approved in some countries and should be approved very soon in France. With randomized trial, non-inferiority trial. It's a C5 inhibitor. The results are exactly the same, but it's given every 2 months. And the crovalimab, that is a anti-C5 developed by Roche, is a sub-Q product, and with results that so far has been shown to be the same than eculizumab. So development of different route of administration, but what we were facing basically with this drug is some unmet needs. So what we did, and I think it's really illustrating this point, was a multi-centering study with our Brazilian and Italian friends, as well as English colleagues in France, Austin Kulaka-Severash from King's College, London. We studied in 160 patients with a median duration, as you can see, of 6 years, what was the impact of eculizumab in our patients. And as you can see already, and that has been published by the UK colleagues, we needed to increase the dose for 20%, 17%, but 20% for the population, which is already showing that for a population, we need to adapt the dose for those patients. And the main result from that study was what is presenting now on the right side of the screen. As you can see, we have 20%, 21.3% of patients who were doing very well with an hemoglobin level of 12 or more, and almost a normal life. But you see that for the other side, you have 40% of patients that were anemic, and we have 26.8% of patients who were not regular transfused, but were transfused once in a while. They were having an hemoglobin level between 8 and 10, and finally you have 12% of patients who are regularly transfused. So you see that in the end, we are coming back to this 30%, 30%, 30%. So if we want to summarize, it's 30% of patients who are doing quite well. Some of them are anemic, but they're not transfused anymore. 30% of patients who are anemic sometimes are transfused because of infections and are living more or less good. And you have 30% of patients that are transfused more regularly in this population. And this is really highlighting the unmet need under eculizumab and the changing goals. I think that we really saved life in 2007, and the complement inhibition was able to protect from thrombosis, protect from death, increase the number of patients coming back to normal life. But now we are changing goals, and the goals now in PNH is really hemoglobin normalization. As you can see here, 40 patients, 38.6% of patients had minor or partial response. In the same time, during those years, what we are showing is that one of the possibility of non-response for patients under eculizumab was extravascular hemolysis. So we have to be very careful with this notion, because before speaking about extravascular hemolysis in a patient with PNH, you have to eliminate all the other causes that might a patient not responding to C5 inhibition. The first one, as you may have seen, is the 20% of patients who are just needed higher dosage. 20% of those patients who are receiving 1200 milligram every 2 weeks. And then coming to the regular causes of inefficiency, like infections. If you are developing a viral infection, you're going to produce some C5, and then you're going to be underdosed because just the inflammations related to the infections, and then everything will come back after the infections. Another thing that you have to think about is, of course, clonal evolution and the plastic anemia evolution. There is a strict and close relationship between idiopathic, I would say, acquired autoimmune plastic anemia and PNH, and patients who might not respond to eculizumab might just be a patient that is evolving to bone marrow failure while having PNH. Another cause that our Japanese friends has been showing up in New England Journal was 10 years ago. It was the C5 polymorphism. And then, of course, eculizumab is not efficient. So when you have eliminated all those causes, then you come to patients, and there are very numbers of patients who are presenting a clinical symptoms related to extravascular hemolysis. So basically, this paper, I think, is the most illustrated one, looking for this complication. You see that you have the CD59 here and the CD53 in abscess, in mixed abscess. And you see that the patients, normal patients, has just cells that are not PNH, so they're expressing the CD59. For cold agglutinin disease, you see that there is a fixation on the cells that are still normal, but you have the fixation of the C3, and so you see this nice population. And then you come to PNH patients, and you see that untreated patients have only two spots, the PNH cells and the normal cells. This is a mixed hematopoiesis with cells having PNH or not. And on the other side, under PNH, under eculizumab, sorry, and this is something that is really redundant in all patients, you have a C3 opsonizations. That makes sense, and we'll see afterwards in the scheme, is that if you are inhibiting C5 at C5 level, you're not protecting from C3 deposition and from the activation, early activation of the cascade. So basically, all cells are C3 fixed, but they are not destroyed because they are inhibited at the level of C5. And what Antonio Rizzitano showed in that nice paper, it was a correlation between reticulocytes. So in other words, if you like, hemolysis, and this level of C3 opsonization. And as you can see, there was a correlation. More C3 deposition you had, more reticulocytes you had. So that was the first study, and then it was confirmed by a study published in Hematologica that was done by Anita Hill from Leeds. It was confirmed that C3 opsonization might play a role in patients under eculizumab. Extravascular hemolysis is absolutely not something seen in PNH patients not treated, of course. We are controlling intravascular hemolysis. We are creating extravascular hemolysis. So then the idea was obviously to try to inhibit the complement earlier to avoid this C3 deposition. And of course, I'm going to speak about pegcetacoplan. That is at the moment the only drug that is approved in Saudi Arabia, but also in the US and probably soon in Europe. But we have other drugs that are targeting at the same level the factor B inhibitor, iptacopan, developed by Novartis, and the factor D inhibitor, danicopan, developed by Alexion. AstraZeneca, if you like. So in other words, there is a lot of efforts worldwide by companies to block at an early stage to avoid this C3 opsonization. So the major studies that has been published already, I guess, 2 years ago, was March 2020 or 2020. Anyway, so it was this level of C3. So just to, again, reinforce my message, as you can see here, this is the complement cascade from C3 to the fixation on the membrane and then activation on T5. And normally you should have a membrane attack complex formation, but the eculizumab is blocking at the level of C5, but eculizumab, as you can see, is not avoiding the fixation of C3. And if the cells are C3 deposition, you have an extravascular hemolysis with the destruction of the cells in the spleen and the liver. On the other way around, if you are using pegcetacoplan, this is a small molecule that is inhibiting at the C3 level, you see that you are protecting not only from intravascular hemolysis, but also protecting from extravascular hemolysis. So you are covering all the complement formation and attack in the cells. So that was the study that proved it was efficient. There was an overlap period, a run-in period of treatment with both eculizumab and pegcetacoplan, and then there was a randomization for receiving pegcetacoplan alone or eculizumab alone. And at the end, all the patients were receiving pegcetacoplan. It was the extension study, and I will show you some results that are not published yet in the second part of my talk. So the inclusion criteria was only adult patients, and as you can see, patients has to be stable under eculizumab for at least 3 months. They have to be less than 10.5 gram per deciliter hemoglobin level, and I see there is a mistake here. The absolute uric acid count should have been more than 100 giga per liter, 100,000 per millimeter cube. In other words, you have to be regenerative to receive that drug. And of course, again, from the beginning of my talk, you should not be with an aplastic component. So this is the distribution of the groups with 41 patients who randomly received pegcetacoplan and 39 eculizumab. As you can see, was perfectly comparable in terms of age, gender, or ethnic background, and there was also a stratifications according to transfusion, with patients who did not receive transfusion yet or patients who received transfusion. So that was the main results of that study. It was the primary endpoint. It was a different hemoglobin level at week 16. And as you can see, there was a drastic difference between groups, with the patients who received pegcetacoplan having 11.5 gram per deciliter hemoglobin at week 16, while it was about 8.6 gram per deciliter at 16 for the eculizumab people. So of course it was drastically significant, and of course it was a success of the primary endpoint. When you go now to the secondary endpoint, you see that all the markers were favoring pegcetacoplan. You see that there was more chance to be transfusion independent under pegcetacoplan, 85% of patients in the pegcetacoplan group, while it was 15% in eculizumab group. You see that there was a normalization of reticulocytes. It was just something that really convinced me that extravascular hemolysis was playing a role, because you see that you're observing, and I will show you in a minute, a decrease in cis-reopsonization, an improvement in hemoglobin level, and a reduced number of reticulocytes. So you're playing on this extravascular hemolysis and improving counts. LDH, no change. And finally, of course, I would say, of course, is really a shortcut, because you have to show what you are saying. So basically, the data were in favor of an improvement in quality of life, but we may imagine that if a patient is gaining 3 gram hemoglobin from the stage he has under eculizumab, it may be associated with a better quality of life. So now, of course, it's good to show efficacy, but you have to show also safety when you're treating patients. So this study has not been published yet. It has been presented at EHA. It was 6 months ago, and it should be published soon. So basically, the idea was to study those patients who were receiving pegcetacoplan for long term of time. So you can see 32 plus 16, 48 weeks, and to see at the end of the week 48, what were the results and how the patients were doing. So first of all, in terms of hemoglobin, as you can see, patients under eculizumab were switched to pegcetacoplan at week 16 with an, again, run-in period. And you see that the hemoglobin level for the whole entire cohort of patients was stable around 11 and 12 in whole patients. So basically, this allows to increase the hemoglobin level stably for all the entire cohort. Another note was about LDH and reticulocytes. As you can see, it was comparable. The LDH were controlled with less than 1.5 normal, and there was no big difference between both groups. And in terms of reticulocytes counts, you see that the patients under eculizumab has extravascular hemolysis. So as I told you, they were anemic with a high reticulocyte count. There was also inclusion criteria. And you see that under pegcetacoplan, those reticulocytes are decreasing drastically to come back almost to normal in the group that were an extension comparable with the group that has been treated straightforward. In terms of transfusion, again, the effect that we've seen in the first 16 weeks in the patients who were randomly assigned firstly to pegcetacoplan was also seen in the patients who switched from eculizumab to pegcetacoplan at week 16. You see that at week 16, the patients who were already in the pegcetacoplan have a stable transfusion independence around 80%, 85% week 16, 73% week 48, while the patients who were under eculizumab at week 16, the 15% I was telling to you before, rise up to 71%, 72% at week 48. So basically, you have a 70-75% chance being transfusion independent if you're under pegcetacoplan in this group of patients, suboptimal responders to eculizumab. In terms of fatigue score, it was what I was saying before. You see that the fatigue score was not doing well when the patients were under eculizumab, and then it reached out the same level when the patients were switched in the extension phase, and that all patients in the pegcetacoplan arm were displaying a better quality of life compared with what has been seen under eculizumab. So what I was saying to you before, and is for me the most striking results from those studies, is the fact that the C3 opsonization is drastically vanished under pegcetacoplan. This is representing the C3 deposition on the red cells under treatment. And as you can see, under eculizumab, you still have a high percentage of cells that are C3 positive, while of course in the pegcetacoplan arm, because of the mechanism of the drugs, you are not seeing anything anymore. And you see that there was a drastic difference between both arms. And then the patients who received pegcetacoplan in the extension arm are again showing a vanishing of the C3 deposition. So we have this correlation between the C3 deposition that is disappearing, the reticulocyte counts that are diminishing, decreasing, because of the mechanism, and the hemoglobin that is increasing. So we are stopping the extravascular hemolysis in those patients. And another note on this is that since you have protected all PNH cells, not only those ones that were destroyed in intravascular, but also extravascular, you're creating patients with 100 PNH hematopoiesis. This is outstandingly important, because it means that the patients have now an hematopoiesis that is related almost exclusively to PNH. So you have some cells that are living because they're protected by a drug. So that's the reason why theoretically we have to be very careful of the condition of breakthrough, because then the patients have no more, I would say, normal hematopoiesis, residual hematopoiesis. So if you are exposing to breakthrough, you're going to have a short and break and acute decrease of hemoglobin level. So that's what I'm coming to now, is a drug discontinuation. And as you can see, if my math is correct, you see that there are 3 patients, for the reason I was precising before, who stopped the drugs in the first 16 weeks because of breakthrough hemolysis, because those breakthroughs are very important and very acute, because of the mechanism I was describing before. And you can see that in the next 32 weeks, there was 3 patients, 1, 2, and there is another one here, that also were facing those very severe and acute and dramatic breakthrough. For the other complication is something that we are normally, I would say, waiting in this kind of population: clonal evolution, polycythemia, bone marrow failure, PNH is an aplastic disease. We also saw some thrombosis, and we have some, of course, unusual complications, B-cell lymphoma. Why? We don't really know why. COVID, I mean, that everybody will agree that it was something that we were all facing in the last 2 years. So you see that basically the main complication here was breakthrough. So the message is also here to say that those patients, of course, they are more exposed to breakthrough because of this 100% hematopoiesis, and we have back and forth trying to see how to protect this from the patient. That is only 6 out of 80, so it's not all the population. Again, for the majority of patients, increased efficacy, safety is okay, and patients are doing better. But then we are coming now to the management of those breakthroughs. Those patients should be very carefully followed. We may reduce the dose increase the dose from 2 to 3 per week at time of breakthrough. We may even envisage, there was some correspondence during the journal that you will be happy to see, where we are saying that a single dose of eculizumab might be helpful in those very particular acute situation, and then of course not stopping pegcetacoplan when the stable level is coming back. So of course, if a drug is working in patients who are suboptimal responders to a treatment, you want to see it first line. So just again, one slide on those results that are not published yet, should be published soon, who are a randomized study with a randomization that is 1.2, 1 patient under eculizumab and 2 patients under pegcetacoplan, and standard of care. I would say standard of care, sorry, and eculizumab no, but pegcetacoplan on the other side. And as you can see, you observed a dramatic increase of hemoglobin level in patients who receive a pegcetacoplan. Again, I apologize to avoid any confusion. As you can see here, the standard of care were excluding any complement inhibitors in the trial. So what is showing this trial, and safety was okay, is that the pegcetacoplan might also be a good option first line in patients. The last message, and I will probably stop with this, is of course the patients who have an hemoglobin level more than 10 but less than 12. So in other words, to understand if the drugs might be in a way a good one in patients who are not transfused, who have an hemoglobin level between 10 and 12. And it looks like this is the case. So it was a retrospective analysis. There was no primary endpoint. The retrospective setting was just an observational trial to see in the studies that has been conducted. The PADDOCK, there was the first studies done, phase 1 study, the PRINCE study, the studies that I showed you before with the randomization for naive patients receiving standard of care outside complement inhibitors or pegcetacoplan, and PEGASUS trial, the first one I was showing to you with the patients who are suboptimal responders to eculizumab. And when you look, even if numbers are really small, you see that there is also an increase in hemoglobin level in those patients who receive the treatment at week 16, even if their hemoglobin level were not so low at time of the beginning. So this is also a nice message to say that all patients might benefit from the drug if needed. So my conclusion is not very, I would say, packed, but it's very important. I really think that we come back from a period of time where patients with hemolytic PNH were dying from thrombosis, and this step has been done. It was eculizumab, revolution in the field, improvement because of thrombosis protection, improvement of overall survival, transfusion independence for some patients, improving in hemoglobin level. We also have some patients who might be pregnant. Remember that before, patients with pregnancy were associated with 20% thrombosis and deaths because of PNH. So yeah, it was really a revolution, and the goal was saving life. I think that now with proximal blockers, we are really changing goals. The new goals is really to come back to I would say, normal life. So hemoglobin normalization, and the main way to avoid this anemic patients is to control extravascular hemolysis. And another message that is outstandingly important, and for the moment, as you can see, there is only one drug that has been approved as proximal inhibitors. The long-term follow-up is not published yet, so we're really at the beginning of the next step. And we have to be very careful to follow those patients outstandingly carefully to really confirm that there is no problem long-term. I have no doubt, but again, if you are blocking the complement so drastically and so deeply, you have to be aware of some theoretical infections risk or cancer risk. So we really have to follow those patients carefully. And the other drugs I speak about at the beginning of my talk, they are only in phase 3 trials. So this is really something that is moving, but we have to be careful as physicians to indicate the treatment to our patients, but to also follow carefully what's going on in the field. And with that, I'd like to thank you very much for your attention. I would be more than happy to take questions. And I also want to thank all my colleagues here at the national level and the international level, because all those studies are done just because of a collaboration between experts. Thank you very much, and happy to take questions.
Thank you, Prof. Regis, for this very elegant overview of the update on PNH. So now the floor is open for any questions. I see no questions in the chat box, but Prof. Regis, a question on natural history of PNH. Is there any chance that some of these patients somehow eradicate the PNH clones, other than the transplant, of course, with all its complications?
Yeah, it's a very nice question. And yes, you are right. We have, I would say, 1 to 2% of patients that are spontaneously evolving and with a PNH clone that is disappearing. We don't know yet why. This is also a message for our colleagues to follow the PNH clone carefully, at least yearly. This is exceptional, but of course, if a patient is coming back to, I would say, normal hematopoiesis, then you have to stop all treatments. In our experience, it's 1-2%.
Thank you. What is your take on transplant to cure these patients and in your experience?
So we published this, I think it was 2016 in Hematologica, just for those ones that wants to refer to the paper. It was the European experience, 211 patients. So what we showed in that trial, it was for a plastic anemia, there is no doubt. Patients with a plastic anemia, severe bone marrow failure, when you have a sibling donor, or if you're refractory to immunosuppression, transplantation as a space, there is no doubt on this. For the patients that have thrombosis, basically the toxicity about transplant was outstandingly high. So I would say that it's a really bad indication. Patients who have PNH and thrombosis, transplantation is really giving worse results. And we even compare to a standard of care of patients not being transplanted, but presenting thrombosis, and transplantation was doing worse. So that's the opposite. And then you have patients with hemolytic PNH. So basically, we have a 15% mortality. It means that when you're transplanted 100 patients with hemolytic PNH, you have 15% of patients who are going to die about the procedures, and then you have half of the patients that are going to suffer in chronic GVHD. So my message here for hemolytic PNH is that when you don't have access to eculizumab or to mainly proximal inhibitors and Empaveli at the moment, you may try transplant because you want to see your patients dying about the disease. But if you have complement inhibitors, then of course it's better to go to complement inhibitors.
Thank you. There's one question here from Dr. Ali Hussein on why patients are microcytic despite their hemolysis is intravascular.
So we have some patients that may have some microcytosis that are, I would say, arriving with time. This is mainly, of course, because of the iron loss due to hemolysis. There is less seen under complement inhibitors, and there is sometimes people saying that if we're giving iron, you're favoring crisis. I mean, at the time the patient is presenting iron deficiency, and we are more or less sure it's coming from the hemolysis and the disease. It's good also to give some iron to those patients.
Very good. Question on elective surgical procedures in PNH patients. Do you have any concerns other than VTE prophylaxis, like hernia surgery or something like that?
I'm sorry, I didn't understand the question.
Elective minor to moderate surgical procedures on PNH patients. Do you have any
okay, sorry. Yeah, so what we are advising is, first of all, to do it. I mean, if it's acute, you have to follow carefully the LDH and then to be very careful with breakthrough and rejecting complement inhibitors if the LDH are rising up and the hemolytic anemia is coming back. So it's for acute procedures. For, I would say, plain procedures, we are mostly doing it just after the injection of complement inhibitors and following the blood counts to see what's going on, and then reinjecting earlier if the hemolysis is coming back.
So I have a patient who is refusing treatment altogether, all PNH therapies, and he's planned for elective hernia repair. Would you try to convince him to take one dose, maybe just to do the
day before? Yeah, one dose the day before. I would not change the schedule. I would just do the surgery just after the complement inhibitors injection, and then I will follow him carefully on the blood counts to see if we need to re-inject earlier the next dose.
Thank you. I see no more questions in the chat box, but I have a last question, please, on future of PNH therapy, including combinations, and this will be only in, when these drugs become affordable. So what do you think of the theoretical possibility of the combination of these drugs when they become at reasonable prices, or other therapies that may that are on the horizon for this disease?
Yes, thank you very much for this question. I think that we are entering in a period of confusion worldwide, because there are going to be many drugs that will be available, and it's going to be difficult for a physician and colleagues to make the choice. I'm not sure that combination is a good thing for patients and also for economy. I would say that patients don't want to take many drugs for their disease, and we don't really know what will be the impact of even more drastic a blockage of the complement. I think we should really all worldwide rise to the most monotherapy, most useful and efficient and safe monotherapy in our patients. I know that combination might be prone by some companies, but really patients want to take only one pills, and they want to take something that is really, I would say, efficient and safe. So I would more prone to have one treatment for patients than a combo, and then honestly in 5-10 years from now, yeah, it's going to be a revolution with all those drugs. So we really have to be very careful, and probably to prone education to help our colleagues to choose the best one for our patient.
Regis, I really enjoyed your talk. Thank you very, very much